Welcome. This presentation will provide an overview of the Suffolk Care Collaborative Cardiovascular Wellness and Self-Management Program. The learning objectives of this session are to demonstrate the elements of a Delivery System Reform Incentive Program, or DSRIP, Cardiovascular Wellness and Self-Management Program, also referred to as Project 3BI. Review major strategies, goals, and tools of the Million Hearts campaign. Recognize how a registry is used to identify and track patients with hypertension, and to summarize key points from guidance recommendations. Hypertension is the most common condition seen in primary care and leads to myocardial infarction, stroke, renal failure, and death if not detected early and treated appropriately. Nearly 1 in 3 adults in the United States has hypertension, and it is estimated that more than half do not have their blood pressure under control. Cardiovascular disease causes 1 out of every 3 deaths and has an associated healthcare cost of over $310 million per year. Cardiovascular disease is the leading cause of preventable death in people 40 to 65 years of age, and there are more than 2 million heart attacks and strokes in the United States every year. The goals of the Cardiovascular Wellness and Self-Management Program include implementation of evidence-based best practices for adults with cardiovascular conditions in clinical practices in the community and ambulatory care. These strategies are focused on improving practitioner population management, adherence to evidence-based clinical treatment guidelines, and the adoption of activities that will increase patient self-efficacy and confidence in self-management. Strategies from the Million Hearts campaign are strongly recommended. The first short-term goal of the Cardiovascular Wellness and Self-Management Program, to integrate evidence-based strategies, clinical guidelines, and effective patient education into clinical practice, are actions to improve delivery system design. The second short-term goal, to document at least one self-management goal identified by the patient in the medical record, which is reviewed and updated at each patient visit, are actions to optimize patient engagement and partnership in health. The first long-term goals of the Cardiovascular Wellness and Self-Management Program are to improve access and management of hypertension and hypercholesterolemia in Suffolk County as evidenced by decreasing the admission rate for patients with a principal diagnosis of hypertension and heart failure, and adequately controlling blood pressure for patients with a diagnosis of hypertension. The second long-term goal is to increase the percentage of high-risk patients that have had a documented discussion with relative risks and benefits of aspirin use, who use aspirin when indicated by clinical guidelines, who are dispensed and adhere to the use of statins per clinical guidelines, who undergo LDL-C testing and are managed in accordance with cardiovascular condition clinical guidelines, are advised to quit smoking and were recommended for smoking cessation medications and strategies, who receive flu shots, and to improve health literacy as measured by the CAHPS survey Health Literacy Measures 13, 14, and 16. Patient engagement in this project is measured and defined as the number of patients 18 years of age or older with the principal or secondary diagnosis of hypertension or hypercholesterolemia receiving services from particular providers with at least one documented self-management goal identified by the patient that is documented in the medical record and reviewed and updated at each patient visit. Examples of goals the patients may identify could include losing weight, increasing their activity level, or stopping smoking. This program has 11 clinical metrics. The first measure, controlling high blood pressure, is applicable to individuals ages 18 to 85 with a diagnosis of hypertension. The target blood pressure indicating control is either less than 140 or 150/90 based on age criteria and/or the presence of an associated diagnosis of diabetes. Statin therapy for patients with cardiovascular diseases includes 2 metrics. First, that they were dispensed at least one high or moderate intensity statin medication, and secondly, that they achieved 80% of days covered for the treatment period. Both metrics are applicable to males ages 21 to 75 or females aged 40 to 75 who have had a myocardial infarction, coronary artery bypass surgery, or a percutaneous coronary intervention in the year prior, or a diagnosis of ischemic vascular disease in both the measurement year and the year prior. 6 measures are assessed through the CAP survey and include aspirin use, flu shots, health literacy, and medical assistance with smoking and tobacco use cessation. The aspirin use metrics include the number of respondents who report currently taking aspirin daily or every other day as applicable to men ages 46 to 65 years with at least one cardiovascular risk factor, or ages 66 to 79 years regardless of risk factors, and women ages 56 to 79 years with at least 2 cardiovascular risk factors. The next measure, flu shots for adults ages 16 to 64, is the number of respondents who have had a flu shot in the age cohort. For quality of health literacy questions 13, 14, and 16, the measure is the number of responses of usually or always to whether the instruction for caring for conditions were easy to understand among respondents who answered that they saw a provider for an illness or condition and were given instructions. Medical assistance with smoking and tobacco use cessation is measured with 3 CAP survey questions. The numerator is the number of sometimes, usually, or always responses to the correlating question of whether they were advised to quit, had a discussion of cessation methods, and discussion of cessation strategies among respondents ages 18 years or older who smoke or use tobacco some days or every day. Prevention Quality Indicator number 7 and number 8 are related to preventable hospital admissions for hypertension and heart failure, respectively. The numerator is the number of admissions with a principal diagnosis of hypertension or heart failure of people 18 years or older as of June 30th of the measurement year. The Million Hearts is a national initiative which launched in 2012 with the ambitious goal to prevent 1 million heart attacks and strokes by 2017. The Centers for Disease Control and Prevention and the Centers for Medicare and Medicaid Services co-led the initiative on behalf of the U.S. Department of Health and Human Services. Million Hearts aims to prevent heart attacks and strokes by improving access to effective care. Improving quality of care for the ABCs of heart health. Focusing clinical attention on the prevention of heart attack and stroke. Activating the public to lead a heart-healthy lifestyle. And improving the prescription and adherence to appropriate medications addressing the ABCs of heart health. The ABCs of heart health include aspirin usage when appropriate, blood pressure control, cholesterol management including screenings, fasting LDL testing, and risk stratification intervention based on clinical characteristics and results, and smoking or tobacco cessation. The Million Hearts website offers useful tools for providers to support their practices, such as registries to support identification of at-risk individuals, hypertension treatment protocols, action guides, hypertension prevalence estimator, and protocols for tobacco cessation. Providers can also find tools to support working with patients. These include a patient visit checklist, information on improving medication adherence, videos and action guides for self-measured blood pressure monitoring, and other communication tools and resources. Many patient tools are also available in Spanish. The website offers resources for patients as well, including a heart age calculator, videos about blood pressure measurement, and resources for dietary support and physical activity. Using a registry is considered to be a useful strategy in identification and follow-up of patients with hypertension. Each practice will determine how to best implement a patient registry based on their staffing model and workflow. A hypertension registry can be used to identify patients with elevated blood pressure measurements without a diagnosis of hypertension for follow-up blood pressure checks, to identify and track patients with uncontrolled hypertension or who have not had a follow-up visit, and to follow up and manage patients using a self-measured blood pressure monitoring device. In 2014, Evidence-Based Guidelines for Management of High Blood Pressure in Adults was published in the Journal of the American Medical Association. This represented the report from the panel members appointed to the 8th Joint National Committee, the JNC8. We will review some highlights from these recommendations. The reference for anyone interested in accessing the document for additional information is noted here and also included in the reference slide at the end of the module. Recommendation 1 addresses the general population age 60 or older. In this population, treatment should be initiated with a systolic blood pressure of 150 or greater, or the diastolic blood pressure of 90 or greater, with the treatment goal to achieve a systolic blood pressure of less than 150 and a diastolic blood pressure of less than 90 millimeters of mercury. Recommendation 2 addresses the general population under 60 years of age and endorses the same diastolic blood pressure treatment target and goal. For individuals age 30 and older, these recommendations are strongly recommended. Grade A. For individuals younger than 30, the diastolic recommendation was based on an expert opinion. For individuals less than 60 years of age or age 18 or older with chronic kidney disease, a lower systolic blood pressure target is recommended. Recommendation 3 is to use a systolic blood pressure treatment target of 140 or greater to initiate therapy in the general population of less than 60 years of age and to treat to a goal of less than 140. Recommendation 4 addresses the adult population age 18 or older with chronic kidney disease. In this population, a systolic blood pressure of 140 or greater or a diastolic blood pressure of 90 or greater is used to initiate treatment with the treatment goal of less than 140 and 90 respectively. Both recommendations are based on expert opinion. Similarly, Recommendation 5 addresses the population age 18 years or older with diabetes with a target of 140 systolic or 90 diastolic to initiate pharmacologic treatment and to treat to a goal of less than 140 systolic and 90 diastolic respectively. Guidelines on the selection of an antihypertensive agent are also provided. Recommendation 6 addresses the selection of an initial hypertensive treatment in the general non-Black population, including those with diabetes, to include a thiazide-type diuretic, calcium channel blocker, angiotensin-converting enzyme inhibitor, or angiotensin receptive blocker. Recommendation 7 addresses the general Black population, again including those with diabetes, where the initial antihypertensive treatment should include a thiazide-type diuretic or calcium channel blocker. Recommendation 8 addresses the population aged 18 years or older with chronic kidney disease, where the initial or add-on antihypertensive treatment should include an angiotensin-converting enzyme inhibitor or angiotensin receptor blocker to improve kidney outcomes. This applies to all chronic kidney disease patients with hypertension, regardless of race or diabetes status. Recommendation 9 addresses next steps to achieving the main objective of hypertension treatment, which is to attain and maintain the goal blood pressure. If the goal blood pressure is not reached within a month of treatment, options may include increasing the dose of the initial drug or adding a second drug from one of the classes in Recommendation 6, a thiazide-type diuretic, calcium channel blocker, angiotensin-converting enzyme inhibitor, or angiotensin receptive blocker, and to continue to assess blood pressure and adjust treatment regimen until the goal blood pressure is reached. If goal blood pressure cannot be reached with 2 drugs, the addition and titration of a third drug from one of the classes in Recommendation 6 may be required, with the caveat that an angiotensin-converting enzyme inhibitor and an angiotensin receptive blocker should not be used together in the same patient. If the goal blood pressure cannot be reached using only the drugs in Recommendation 6 because of a contraindication or the need to use more than 3 drugs to reach the goal blood pressure, antihypertensive drugs from other classes may be considered. Referral to a hypertension specialist may be indicated for patients in whom goal blood pressure cannot be attained using the above strategy, or for the management of complicated patients for whom additional clinical consultation is needed. Similar to hypertension guidelines, clinical guidelines for managing blood cholesterol were published in the Journal of the American College of Cardiology in 2014 by the American College of Cardiology and the American Heart Association Task Force on Practice Guidelines as the 2013 ACC/AHA Guidelines on the Treatment of Blood Cholesterol to Reduce Atherosclerotic Cardiovascular Risk in Adults. This guideline focuses on treatments proven to reduce atherosclerotic cardiovascular disease events. It does not, and was never intended to be, a comprehensive approach to lipid management. We will review some highlights from these recommendations. The reference for anyone interested in accessing the document for additional information is noted here and also included in the reference slide at the end of this module. Lifestyle modification, adhering to a heart-healthy diet, regular exercise habits, avoidance of tobacco products, and maintenance of a healthy weight remain a critical component of the health promotion and atherosclerotic cardiovascular disease risk reduction. In addition to lifestyle modification, statin therapy is a key intervention that may be high, moderate, or low intensity based on clinical indications, drug tolerance, and outcome targets. On average, high-intensity statin therapy may decrease LDL-C by more than 50%, whereas low-intensity therapy would lower LDL-C by less than 30%. In terms of treatment targets, the panel makes no recommendations for or against specific LDL-C or non-HDL-C targets for the primary or secondary prevention of atherosclerotic cardiovascular disease. The panel does provide recommendations as to the intensity of therapy. For secondary prevention for patients with established chronic atherosclerotic cardiovascular disease, as evidenced by acute coronary symptoms, history of myocardial infarction, angina, coronary or other arterial revascularization, stroke, transient ischemic attack, or peripheral arterial disease, for individuals 75 or younger with no safety concerns, high-intensity statin therapy is recommended. For those older than 75, or with safety concerns, a moderate intensity regimen is recommended. Recommendations for primary prevention in several different scenarios are covered in the next few slides. For individuals 21 years of age or older, with an LDL-C of 190 milligrams per deciliter or higher, it is recommended to evaluate for secondary causes of hyperlipidemia, as well as if triglycerides are 500 milligrams per deciliter or higher. Treatment with high-intensity statin therapy is recommended, if tolerated, unless contraindicated regardless of the 10-year atherosclerotic cardiovascular disease risk estimate. In this 21 years of age or older group, with untreated primary LDL-C of 190 milligrams per deciliter or higher, it is reasonable to intensify statin therapy to achieve at least a 50% reduction in LDL-C. The addition of non-statin drugs may be considered after maximum intensity statin therapy has been achieved to further lower LDL-C if warranted. Patients should be evaluated for atherosclerotic cardiovascular disease risk benefits, adverse effects, drug interactions, and patient preferences. For primary prevention in individuals with diabetes, in LDL-C from 70 to 189, recommendations are based on age and 10-year atherosclerotic cardiovascular disease risk estimate. Moderate intensity therapy is strongly recommended for adults with diabetes and an LDL-C between 70 and 189 who are 40 to 75 years of age. Unless contraindicated, expert opinion suggests high-intensity therapy is reasonable for this group if they have a 7.5% or higher risk for cardiovascular event. Similarly, for ages less than 40 or greater than 75, it is considered reasonable to evaluate the potential for a cardiovascular benefit, adverse effects, drug interactions, and patient preferences when deciding whether to indicate, continue, or intensify statin therapy. For individuals without diabetes, recommendations are based on a 10-year cardiovascular risk estimate. For adults age 40 to 75 with a 10-year atherosclerotic cardiovascular disease risk estimate of 7.5% or greater, moderate or high-intensity therapy is strongly recommended. For those with a 5 to 7.5% risk, it is considered reasonable to treat with moderate intensity statin therapy, which is a grade C recommendation. For any adult not otherwise identified as being in a statin benefit group, statin therapy for primary prevention may be considered after evaluation for potential atherosclerotic cardiovascular disease risk, adverse effects, drug interactions, and discussion of patient preferences. Medication adherence is a crucial factor that may impact achievement of therapeutic goals. Modifiable factors that may impact medication taking behavior include high pill burden, drug tolerability, and cost. Selection of medications that are better tolerated can improve adherence and lower drug discontinuation rates. Once-daily medications and fixed-dose combinations can be considered to lessen pill burden and improve medication adherence. These references are recommended as a resource to provide additional information on this topic. Thank you for watching the Suffolk Care Collaborative Cardiovascular Wellness and Self-Management module.